So obviously, thanks for having us to talk today. So we're going to talk a bit about some work that we'll be doing as part of a kind of EU-funded research consortium called Hypermarker, which is looking at, and the work we're talking about today is around machine learning driven identification of metabolites and hypertension, and utilising these in the context of a clinical study. Great. So I don't think we've got any conflicts. Just a disclaimer, some of the data and data processing that Animesh will present kind of is being utilised in the context of a clinical trial. So we're slightly restricted in some of the what we can present. So just to be mindful of that. So in terms of what we're discussing today, so we'll give you an overview about the project. Animesh is then going to talk about some of the data modelling strategies that have been utilised, and then I'll go over some information about the clinical trial that we've recently started. Great. So the kind of overarching objective of Hypermarker is about whether we can utilize kind of metabolomics, and this term pharmacometabolomics, to individualize and utilize that in the decision making around how we go about prescribing blood pressure medications for individual patients. So in terms of why this work's happening, well, first of all, hypertension has a significant impact at both an individual and system level. This is in part due to its prevalence, and then also the cardiovascular disease that results from it. Cardiovascular disease as a whole accounts for around 11% of the use healthcare expenditure, and hypertension is a major driver of this, contributing to around half of strokes and heart attacks. Improving the treatment of hypertension, we know, can have a major impact to both patients and healthcare systems at large. With every kind of 5 millimeters of drop in blood pressure contributing to a 10% reduction in cardiovascular events, and I'll show you some of the data that's come from. So there are multiple effective pharmacotherapies for hypertension. There's potentially some more kind of going through phase 3 studies at the moment. Broadly, it's accepted that medications should be used at low dose in combination. However, despite kind of what we see in terms of variation in inter-individual and inter-population responses to therapy, the ability to know which combination will be the most effective for an individual patient remains relatively limited in clinical practice. Treatment decisions may often be confined to kind of a small number of medical conditions where secondary complications may have already occurred, such as heart attacks or heart failure. So improving this selection, or if we can improve it, that could potentially have major impact on outcomes, then also the kind of patient experience in terms of both adverse reactions and kind of the adherence. This data here that I present is from the FITZIC trial, which was a double-blind, randomized, repeated crossover trial of single antihypertensive drugs. And this demonstrated a substantial difference in treatment response when they modeled kind of a best treatment approach versus a fixed choice. This demonstrated kind of an average of 4.4 millimeters of mercury drop in blood pressure in addition for that personalized approach. Obviously, there was variation depending on what was deemed the best choice and what it was compared to. But this potentially highlights the potential impact we could have if we were able to kind of select the best medication for that individual patient. And as I said, that those kind of just even kind of what seemed like relatively small changes in blood pressure actually can have significant effects at the individual level. So these are kind of data from a meta-analysis of individual patient level data from across 48 randomized controlled trials across around kind of over 300,000 participants. And this is where this kind of this data comes from in terms of that 5 millimeter drop in blood pressure contributing to around a 10% reduction in cardiovascular impact. And that's irrespective of whether someone has cardiovascular disease at baseline. So really then the Hypermarker project is looking about actually, well, if we can take this kind of more non-specific use of existing drug therapy, whether that potentially has impact on adherence and side effects, can we then kind of downstream see that improvement in overall control of blood pressure, which at the minute still remains relatively poor, particularly globally. In the UK, around only 2/3 of patients have their blood pressure controlled to target. And then if we do this, can we then have that kind of impact on outcomes and that kind of the impact of hypertension at large? So the Hypermarker Consortium, so kind of just giving you an overview of the kind of work that's been going on within the consortium, which is occurs across multiple partners. Obviously, ourselves, the University of Birmingham, are involved. So the consortium work kind of seeks to address this current challenge in the management of hypertension, to see whether it is possible to personalise the choice of medication class that we give individual patients for hypertension, and particularly whether metabolomics is a route or an avenue to achieve this. With metabolomics kind of allowing you to then quantify thousands of metabolites that then may reflect the kind of an individual factors about that patient, from their kind of genetics to kind of environmental contributors that may influence how they respond to treatment. So this gone about, and Animesh will discuss this in more detail, but essentially we've taken data and blood samples from multiple pan-European cohorts. The metabolic profiles have been generated by a team at the University of Leiden from plasma samples using high-resolution mass spec. These are then being combined with kind of conventional clinical features through machine learning approaches, which Animesh will go on to discuss later. And this is about whether we can see or kind of see how someone may respond to an individual drug class, individual drug class of an antihypertensive. This then is being tested in the context of a randomized controlled trial, which then within that we've got additional kind of team from London School of Economics doing some additional economic analysis, and I'll come on to discuss later more details around that clinical trial. The consortium is split into different work packages across multiple institutions within Europe. Animesh is going to talk about that kind of one of those particular work package which the University of Birmingham is leading on, which is around that data analytics and prediction models. Great, so I'll hand over to you, Animesh.
Okay, great. So should I share, Matt, or
up to you, or I can go through whichever's easier.
Okay, great. Maybe you can control. I can just say as next slide to be better. Okay. Hi guys. One of the thing. So, well, I'll be talking about mostly about how we are getting the data and how we are modeling. But because of trial ongoing and the confidentiality, I cannot go too detailed. So I kind of giving you overview what is happening in the modeling aspects. Next slide, please. Yeah, so in terms of me, Kevin already introduced me, but in my lab, I'm interested in three things. Number one is integrative analytics, meaning that given multiple different data types, it could be RNA sequencing, single cell, clinical data, how best we can find a strategy to combine them and the prediction of the phenotype. So that's one of the objectives in my lab. The second is diagnostics or biomarker identification, and these hypermarker project actually very nicely landed up in this particular domain, and not just the identification of biomarker, but how early we can detect the markers in various sort of diseases. And I'm interested in cardiology, but also other inflammatory diseases like IBD, colon cancer, and fibrosis, for example. And the last one is the development of new methodology. So here I'm interested in developing new methodology and statistical modeling, but also machine learning modeling, which is very specific to the method, not specific to the data generated. So meaning that comparing multiple different methods and then see what are the published data is there, and comparing and claiming this methodology might be useful. So it's really a kind of a interdisciplinary area, and we go back and forth in modeling, but also a mechanistic aspect of the markers as well. So here I'll be talking mostly about the second pillar, which is focusing on diagnostic marker identification. Next slide, please. Yeah. So here in that avenue, so one of the work package in hypermarker is mostly on identification of the marker. So there are three broad objectives of this work package. First of all, we wanted to develop a predictive model based on the data we are going to get. And as Matt said, the data is mainly the clinical data and metabolic data. Also, metabolic data came to us in a two different format. One is the targeted metabolomics coming from LCMS, meaning that we have around 100 metabolites. We know the annotation of those metabolites, meaning that those 100 metabolites around, we know the mechanism, how the pathways and all the things are working. The second set of data we got, which is untargeted in nature, meaning that we have around 2,000 peaks, mass peaks. We don't know which metabolite actually those are. And we wanted to blend some extent all together in this model. And the third one is, once we identify the marker, how we can develop some causal modeling. Now this is very confusing, the people who are coming from the experimental domain. So sometimes they confused with the experimental causality, but I am talking about 100% mathematical causality. And here we are interested causality, not by genetics or by DNA causality, but just clinical data and the metabolic profiling. So mostly on the theoretical framework or simulated framework, how identified metabolite may be acting there. All right, next slide, please. Okay, so Matt already touched upon. So we have got the data from 4 different cohorts, and as you can see, they are coming from multiple different countries. Swedish cohort, Matt already talked about that. This is the trial data, which quite clean in terms of the intervention. So they have given a drug. We know drug is working or not. The second one is coming from the Germany, where it's a cohort generated from different cardiac diseases, and hypertension measurement is there as well. Alpha omega cohort, which is called AOC, which is coming from Netherlands, and then UCC smart cohort also coming from the Netherlands. So the first and we have got these data in a sequential fashion, meaning that we have not got all the data in a single go. So we have to develop the strategies, given that once each data sets are coming in, how we are blending into that and how we are going to update the model in that case. So now I'm talking about, we have all the accessibility of the data sets, and you understand each data is coming from different countries. They have a different bias involved in this data. They have maybe the patient suffering from multimorbidity and many other things. The first thing we have done, looking into how similar these cohorts are. So doing some principal component analyses and looking into if the data is different. And actually we find the data is quite different, and as expected. We have corrected those data set using the combat and many other algorithms in this, and made a concrete a new cohort. And this is the cohort we use for the training purpose in this. And our outcome variable is the blood pressure 5 mm decrease in given specific drug. So that is our outcome variable. And our predictor variables are clinical features and the metabolic features. In this first phase, we have run the targeted metabolites. Next slide, please. Yeah, so this is actually, I think I have touched upon already around those lines. So we are in work package 4, but work package 3 also looked at the data which is existing data. So work package 3 looked at the UK Biobank data, some extent the CORA cohort, many other existed data, to find a way or avenue that if there are any kind of a common signals around those lines, and then from the work package 3, if you can learn something and fuse into the work package 4. Yeah, so maybe I'll come back to this one, how we blended the work package 3 knowledge to work package 4. But let's talk about a little bit more on the strategy, how we did the modeling of those data sets. Next slide, please. Yeah, maybe you can go one more step. Yeah, so here, I mean, as I mentioned earlier, all the cohorts kind of aggregated in this case. So we have developed kind of a in the literature as well, the nested stratified cross-validation strategies. In that case, with the inner outer cohort, using think about the data leakage aspect as well. So we did not normalize entire data in the same go. We take into account each of the cross-fold coming from the training set, different way we have imputed and normalized. So the final validation set doesn't know really how we have done it in a kind of a blind way, so that we can get a predictability and can be implemented in the trial settings. Next click, please. Yeah, go ahead. Yeah. Yeah. So the way we have done it is like training the model using only the baseline model. For example, using the age, gender, BMI, different hypertension related other clinical features, and looked into the predictability. So when I'm talking about the predictability, we looked at all sort of things: the sensitivity, specificity, precision, AUC, macro AUC, micro, all these kind of thing. Then the full model, meaning that given all the clinical features and all the metabolic, around 100 features, how the model behaving, and because this model will be going for further the clinical decision support system, so there was a need for selection of those metabolites. And then we actually tried many different algorithms, starting from XGBoost, starting from random forest, starting from neural network model, many other models. However, based on the European consortium, our model need to be interpretable. So we top of the model building, we have included Lyme and Sharp values, so that we can identify the metabolites which can be kind of a we can select those metabolites. However, we find one of the method is performing very well. And if you go to next slide, please. And this is the lasso, and you, many of the audience probably knowing how does lasso work. Is kind of a selecting optimum features given a large number of metabolite or features, take into account the correlation structure as well. And so we have used lasso and together with other modeling strategy, and seems like a lasso not only picking up the metabolite, smaller set of metabolites in each of the fold. So each of the fold we estimated which metabolites are coming, and did some sort of a stability analysis as well. Top of it, the lasso selections, overall selection versus fold-wise selection. Next slide, please. Yeah. So and then we kind of derive the optimization function based on all the metabolites versus the AUC. So if I mean, there is no figure, but because of the confidentiality, I couldn't put the figure. But what all we have done here is putting x-axis the number of metabolite, and y-axis is AUC and F1 score, and running the optimizations and asking how many metabolite in each of the fold is giving me optimum number of AUC. And then we saw around 20 to 30 metabolites is optimum. And finally, we selected 28 metabolites, which is giving us the best AUC performance. And those metabolites further gone into the pipeline for cross-checking the interactions with the drug, for cross-checking the interactions with the clinical features, and making those very targeted modeling approaches. Next slide, please. Yeah, and then if you go to the next one as well. Yeah, and then once we have identified those, and as I mentioned earlier, how we can learn the causality. So as causality is very hard to learn in the literature, and people have used different graphical models. Here also we have used very kind of a simplistic approach. We computationally we take out one node. Each of the node represent my metabolites, and as you can see, this is 0104. These are representing the metabolite name. The M, you can see the central hub. Hub meaning that maximum connectivity with the metabolite. In this case, so we identified the hub, one of the clinical features, which is regulating some extent other metabolite in the process. Now, question arising that, okay, if those metabolites are really kind of a isolated, or they kind of a regulating some biological phenomena, in this case pathways as well. So what we have done, we have projected those metabolite in the pathway databases. There are many different pathway databases like lipid maps, XCMS, and many others, enrichment analysis based approaches. And we identified specific pathways for these analyses, which is kind of a perturbing the system. So once we have done it, the question is, okay, how do you identify the causality? So we take out randomly one of the node and estimating the effect, and we compare iteratively in this fashion, and assuming it's like a mimicking the knockout experiments in a way in the system. So in the knockout experiment, what we do, either we overexpress the expression value, or we underexpress, or we knock out the system, and because of it, there is an overall system level perturbation is happening, and we can estimate the effect size there. We have tried to do similar thing here. We have take out one node and trying to estimate what are the effect is happening because of one node, and how much, because the entire system is now perturbed, we can estimate the cause, kind of a tentative again, because we're not doing an experiment, it's like a tentative one. So and then we kind of made a framework around those lines, and we have validated some extent what work package 3 actually found. So work package 3 found some of the metabolites, some of the pathways, based on the meta-analysis, based on the systematic review, and we try to align those knowledges. So meaning that if we find any evidence came from work package 3, we weighted the graph. Okay, so essentially this is a weighted, undirected graph in a way. Anyway, so we have done all this exercise, and then maybe next slide, Matt. And then we come up with a kind of a interface of the data flow, how the data is happening. So once we have done the exercise, the question is how we can implement in the real settings. So we have used University of Birmingham RADCAP for the system, because the trial is going to happen. Patient will be coming in, will be measuring, will be mimicking, because our model is ready. And then when the patient is coming in, the system should be able to predict what is happening with this particular patient and what kind of drug we are recommending. So here, as you can see, this is going very collaborative way. Leiden University doing metabolic profiling. So metabolic information is coming from UV data sets from Leiden. UV has a RADCAP, so the implementation is done in RADCAP. Viduet is a SME based in Netherlands. They are measuring the blood pressure. So we are getting the blood pressure for the patient as well, and it's kind of giving an ecosystem of metabolite, drug, and interactions, and the kind of a recommendation kind of a system. Next slide, please. Yeah, so I'll pass it to Matt to talk about a little bit more on the trial and how we are designing the trial in this case.
Yeah, perfect. Thanks, Animesh. So I'm just going to go over the kind of structure of the randomized controlled trial that sits within the wider consortium work, and utilizes some of the modeling that Animesh has done. Great. So first, before I kind of talk about the trial design of things, just to acknowledge the contribution of the patient public group that have contributed to key elements of the trial design and the deployment of the study. The group represents has representatives from kind of all across all trial sites, and it's been coordinated with our collaborators at the European Heart Network. I won't show you the video, but this patient study video that has been kind of designed and deployed by the patient team. Just move my slide across. Oh, it's playing. Good. So the hypermarker trial is the first randomized controlled trial to evaluate this kind of pharmacometabolomic guided approach to aid the choice of blood pressure class selection. So the trial is a proof of concept study which has been designed to be pragmatic and adaptive, and it's really a strategy trial which looks to embed in kind of routine clinical practice. Patients are randomized with a stratified randomization model, and the study is sponsored by the University of Birmingham, and as we've said, it's funded by the EU with funding also from the UK Research and Innovation. Just trying to move my slide across. So the trial is now open to recruitment. We're looking to recruit 400 eligible patients with a blood pressure of 140 or more and a clinical indication for the treatment of high blood pressure across multiple European secondary care sites. As the trial is embedded in routine clinical practice, patients can be identified during their routine secondary care encounters, such as outpatient clinics, and then immediately brought into the study for initiation of treatment through the study. Obviously, following consent, we have one baseline visit where we can conduct kind of the ACRF completions, patients complete patient-reported outcome questionnaires, and then the participant provides a blood sample and completes a supporting dietary questionnaire. They're then set up with a study app and a blood pressure device, which we'll come on and discuss more, which allows at-home blood pressure data collection, allowing the rest of the study essentially to occur remotely. So following written consent, participants are randomized in a 1-to-1 ratio to either standard of care or the use of this kind of pharmacometabolic approach to a treatment clinician decided treatment selection. Randomization stratified by site, patient participant's age, and their baseline office blood pressure. Standard of care aligns to the 2024 European Society for Cardiology guidelines and management of elevated blood pressure and hypertension. And the intervention, which obviously Animesh just kind of just discussed some modeling that's got into that, provides kind of person-specific drug class decision support that clinicians may then utilize when making their own choice of a blood pressure lowering medication. Great. So following enrollment, as I said, the trial can be conducted remotely with the provision of this at-home blood pressure device, which is provided by the team in the Netherlands called the Duet, and their smartphone application. So each participant is asked to capture at least 1 week of at-home blood pressure measurements after randomization and before any medication changes. And then their medications are reviewed depending on their randomization. And then after they're asked to conduct a further 4 weeks of at-home blood pressure measurements, and then they complete a set of patient-reported outcome questionnaires, which include things like quality of life, medication adherence, and adverse events in healthcare utilization across that 4-week period. The pharmacometabolic approach is planned to be iterated and refined during the trial, with all participants then subsequently having their medication class re-reviewed, so this time with all investigators or clinicians having that additional information from the pharmacometabolic approach. The participants then asked to complete a further 4 weeks of at-home blood pressure recordings and then a final set of questionnaires. There's then an optional end-of-trial visit where participants may then come back in and provide a further blood sample for metabolomics so that we can compare pre and post-treatment. So the primary outcome of the study is home systolic blood pressure, comparing the intervention and standard of care groups in that first phase of the study. There's major secondary outcomes, which include the proportion of patients achieving guideline-defined target blood pressure, patient-reported adverse effects, quality of life, treatment withdrawals, and adherence. In addition, as I said, through work with a team at the London School of Economics, Hypermarker will also demonstrate methods for kind of healthcare pathways and health economic evaluation to underpin any future implementation post the work of the consortium. Great, so just put the inclusion-exclusion criteria up here. So broadly, we're looking we're recruiting patients that are over the age of 18 with a blood pressure of 140 or more, and a clinical indication for starting or adding antihypertensive therapy. The exclusion criteria predominantly limited situations that require specific drug treatments or this is obviously just to maximize the generalizability of findings. So Animesh has obviously already highlighted the work that's gone into the kind of the intervention, which provides additional information that a clinician may then utilize when making their own choice of which drug class to select for an individual patient. That information stems from the metabolites of interest measured from the participant's baseline sample alongside conventional clinical variables collected during the ECRF completion and the blood pressure data collected through the at-home blood pressure system. As I said, the models then plan to be iterative and undergo refinement during the trials. We get additional data from this study and then any additional data that comes in from existing cohorts. So in terms of the at-home blood pressure system, so this essentially people's blood pressure is measured using a semi-automatic validated monitor, which is the Rosmax Z5. Then using a secure Bluetooth protocol, measurements are transferred to a mobile application on their phone, which is, as I said, the Viduet Health app, and then securely transferred to a joint patient, physician, and researcher portal to inform medication reviews, with then data exports coming into the University of Birmingham for that model and for modelling and then the trial outcomes. Home blood pressure measurements will be taken at least 3 days per monitoring week, with participants asked to record at least 2 measurements in the morning and 2 in the evening on each measurement day. To ensure compliance with protocol, participants then can also receive notifications alongside notifications that go to site to ensure kind of compliance with protocol alongside throughout the study. Great. As Animesh already alluded to, we're utilising the REDCap system in the University of Birmingham for the kind of trial platform. And then also the completion of the patient-reported outcome questionnaires. And as Animesh has already shown, this platform is then being utilised in terms of bringing in that kind of modelling data through an API from the kind of University of Birmingham secured data platform. Great. So that's just to give you an overview of the kind of wider work of the Hypermarker Consortium. Obviously, Animesh has covered some of the modelling techniques that have been used and how we've processed that metabolic data, and obviously just discussed how that's then been deployed in the context of a randomised clinical trial, which is actively recruiting at present. So I think it's just to highlight, obviously, the Hypermarker Consortium. We've got many partners working across the different work packages in the consortium. It's just obviously to acknowledge the work of all of those. Great. I think that is we had.